Question 1. Topic: EKG interpretation and analysis. Atrioventricular AV blocks. 67-year-old patient comes into the emergency department complaining of dizziness and fatigue. An EKG is performed and it reveals prolonged intervals that are consistently delayed but with each P wave followed by URS complex. The patient has no history of heart disease but is currently taking beta blockers for hypertension. Based on these findings, what type of conduction abnormality is most likely present? A. First degree AV block. B. Second degree AV block type I. Wenkibo. C. Second degree AV block Dapomentubit Romantui. Third degree AV block complete heart block. Answer A. First degree AV block. Explanation. A first degree AV block is characterized by a prolonged interval, 200 ms, without any drop RS complexes. Since every P wave is followed by a URS complex in a delayed but consistent manner, this matches the description given in the question. Second degree AV block type I. Wenkebot is incorrect because it shows progressive interval prolongation before. A drop core second degree lock time is incorrect because it involves randomly drop core complexes without prolongation. Third degree AV block complete heart block is incorrect because it presents with no association between P waves and RS complexes, meaning atrial and ventricular rhythms are independent. Beta blockers, such as those the patient is taking, can slow AV node conduction and contribute to first degree AV block, but they do not cause high degree blocks unless other underlying conditions exist. Question 2. Scenario-based. Topic: infection control and safety procedures. Biohazard handling and disposal. Sarah, newly certified EKG technician, is performing an EKG on patient in an outpatient clinic. After completing the procedure, she notices that one of the electrodes has blood on it. She is unsure of the best way to handle the contaminated equipment. Which of the following is the most appropriate course of action? A. Disinfect the electrode with an alcohol wipe and reuse it for the next patient. B. Dispose of the electrode in standard trash bin as it is not sharp object. C. Place the contaminated electrode in biohazard waste container for proper disposal. D. Soak the electrode in bleach solution for 10 minutes before reuse. Answer. C. Place the contaminated electrode in a biohazard waste container for proper disposal. Explanation. According to OSHA and CDC guidelines, any item contaminated with blood or bodily fluids must be properly disposed of in a biohazard waste container to prevent the spread of infection. Option is incorrect because alcohol wipes are not sufficient to fully disinfect an electrode contaminated with blood. Option B is incorrect because biohazardous materials should never be placed in regular trash bins as they pose a risk of disease transmission. Option D is incorrect because soaking reusable electrodes in bleach is not a standard procedure. Disposable electrodes should not be reused. Proper infection control measures protect both healthcare workers and patients from exposure to bloodborne pathogens like HIV, hepatitis B, and hepatitis C. Question 3. Topic: EKG equipment and troubleshooting. Lead reversal and misplacement corrections. An EKG technician is reviewing 12 lead EKG tracing and notices that lead I shows inverted P waves and a normal or S-axis and flipped T wave. The rest of the tracing appears relatively normal. What is the most likely cause of this abnormality? A. The patient is experiencing right-sided myocardial infarction. B. The EKG leads were improperly placed, likely with right and left arm leads reversed. C. The patient has new onset left bundle branch below BB. D. The machine's paper speed was accidentally set too high, causing distortion of the tracing. Answer. B. The EKG leads were improperly placed, likely with right and left arm leads reversed. Explanation. Lead reversal is a common cause of abnormal EKG findings that mimic serious cardiac conditions when the right arm and left arm leads are accidentally switched. Lead I shows negative deflections, inverted PQRS and T waves because the expected electrical activity is recorded in the wrong direction. The Roman to Roman rate also show atypical waveforms but are not as dramatically affected as lead I. Option is incorrect because a right-sided myocardial infarction would typically present with segment elevations in right-sided chest leads VV and low Roman. Option C is incorrect because left bundle branch below BB presents with a widened RS complex 120 ms, a characteristic a notched R wave in leads VV and V6. Option D is incorrect because paper speed issues affect the timing of waves, not the polarity of electrical activity. To prevent errors, EKG technicians must always double-check electrode placement before running an EKG, following the standard lead placement protocol. Question 4. Topic: cardiac medications and their effects on EKG. Beta blockers. An AV conduction 72-year-old male patient with history of hypertension and atrial fibrillation is prescribed metoprolol beta blocker. After taking the medication for a few weeks, he starts experiencing fatigue, dizziness, and occasional near syncope. An EKG is performed and shows prolonged interval with no drop QRS complexes. His heart rate is also lower than his baseline. Based on these findings, what is the most likely reason for his symptoms? A. The patient has developed second-degree AV block Roman due to metoprolol toxicity. B. The beta blocker has slowed AV conduction, leading to first-degree AV block and bradycardia. C. The patient's atrial fibrillation has worsened, causing irregular conduction and resulting in symptoms. D. The patient has developed digoxin toxicity, which is causing conduction abnormalities. Answer B. The beta blocker has slowed AV conduction, leading to a first-degree AV block and bradycardia. Explanation: beta blockers like metoprolol slow conduction through the atrioventricular AV node, leading to a prolonged interval. This can cause bradycardia and symptoms like dizziness or fatigue, particularly in older patients. Option is incorrect because second-degree AV block is more commonly associated with structural heart disease and not typically a direct effect of beta blockers. Option C is incorrect because worsening atrial fibrillation would present with an irregularly regular rhythm, not a prolonged interval with a steady rhythm. Option D is incorrect because digoxin toxicity causes scooped segments, digoxin effect, and more severe AV blocks, but the patient is not on digoxin. Key concept: beta blockers decrease sympathetic stimulation of the heart, which can be beneficial in conditions like atrial fibrillation but may lead to excessive bradycardia and conduction delays, particularly in elderly patients. Question 5. Scenario-based. Topic: EKG interpretation and analysis. Ventricular arrhythmias in emergency response. Mr. Jackson, 58-year-old man with history of coronary artery disease, is undergoing routine EKG in clinic when he suddenly reports severe chest pain, shortness of breath, and dizziness. The EKG technician observes wide QRS complex tachycardia with rapid rate of 180 bpm, no visible P waves, irregular RR intervals. What should the technician do first? A. Instruct the patient to take deep breaths and wait to see if the arrhythmia resolves spontaneously. B. Call for emergency assistance and notify the healthcare provider immediately. C. Perform carotid sinus massage to try to slow the heart rate. D. Continue monitoring the patient while completing the full 12-lead EKG. Answer B. Call for emergency assistance and notify the healthcare provider immediately. Explanation: the patient is likely experiencing ventricular tachycardia (VT), which is a life-threatening condition. Wide QRS tachycardia 180 bpm with symptoms, chest pain, dizziness, shortness of breath is an emergency requiring immediate intervention. Option is incorrect because VT is unlikely to resolve on its own, and delaying intervention increases the risk of cardiac arrest. Option C is incorrect because carotid sinus massage is used for supraventricular tachycardia, SVT, not ventricular arrhythmias. Option D is incorrect because continuing the EKG instead of calling for help wastes critical time in an emergency. Key concept: ventricular tachycardia, VT, can lead to cardiac arrest. If the patient is unstable, immediate electrical cardioversion is required. Calling for emergency assistance is the top priority. Question 6. Topic: specialized EKG testing. Holter monitoring and event monitoring. Patient is experiencing occasional palpitations and dizziness, but multiple in-office EKGs show normal sinus rhythm. The physician orders an ambulatory cardiac monitoring study to capture any intermittent arrhythmias. Which test would be most appropriate for detecting transient arrhythmias that occur only few times per week? A. Standard 12-lead EKG. B. Continuous Holter monitor 2448 hours. C. Event monitor loop recorder. D. Exercise stress test. Answer C. Event monitor loop recorder. Explanation: an event monitor is best for patients with infrequent symptoms because it records only when the patient experiences an event, either automatically or by patient activation. Since the patient's symptoms occur only a few times per week, a 2448-hour Holter monitor, option B, is less likely to capture an episode. Option is incorrect because a standard EKG only captures a few seconds and is unlikely to record an intermittent arrhythmia. Option B is incorrect because Holter monitoring is continuous but only for 2448 hours, making it ineffective if symptoms occur less frequently. Option D is incorrect because the stress test is useful for detecting exercise-induced arrhythmias, which are not described in this case. Key concept: Holter monitors are best for frequent arrhythmias, daily symptoms. Event monitors are best for infrequent, transient arrhythmias, symptoms, a few times per week. Question 7. Topic: egg waveforms and interpretation. Segment abnormalities. 55-year-old patient presents to the emergency department with crushing chest pain that radiates to his left arm. An EKG is performed and shows segment elevation in a Roman terminal depth. What is the most likely diagnosis? A. Anterior wall myocardial infarction MI. B. Lateral wall myocardial infarction MI. C. Inferior wall myocardial infarction MI. D. Pericarditis. Answer: C. Inferior wall myocardial infarction. My explanation. Since segment elevation the Roman terminal F indicates an inferior wall myocardial infarction which affects the right coronary artery. RCA option is incorrect because an anterior would show elevation in leads VVV lead artery involvement. Option B is incorrect because a lateral would show elevation in leads I AVA-V and V6 circumflex artery involvement. Option D is incorrect because pericarditis typically shows diffuse elevation in all leads, not localized changes. Key concept: inferior elevation in Roman of RCA occlusion, anterior elevation in VV ad occlusion, lateral elevation in I AVA VV V6 circumflex occlusion. Question 8. Topic: EKG interpretation. Bundle branch blocks and WAD CORS complexes. 67-year-old male with history of hypertension and coronary artery disease presents to the clinic for routine checkup. An EKG CORS duration of 140 ms, broad R wave in lead V and deep S wave in leads I and V6. What is the most likely diagnosis? A. Left bundle branch block B. Right bundle branch block B. C. Ventricular tachycardia VT. D. Hyperkalemia induced conduction abnormality. Answer: B. Right bundle branch block B. Explanation: right bundle branch block B is characterized by wide ORS complex 120 ms or 0.12 sec row pattern in V, M-shaped QRS rabbit is. Deep S wave in lead I and V6. Option B is incorrect because LBB shows broad monomorphic R wave in leads I and V6 without an R pattern in V. Option C, VT, is incorrect because VT usually shows monomorphic wide complex rhythm at rapid rate. Option D, hyperkalemia, is incorrect because hyperkalemia causes peaked T waves and ORS sidening but does not present with an ORR pattern. Question 9. Scenario-based. Topic: EKG artifacts and troubleshooting. A 45-year-old woman is undergoing a routine EKG in an outpatient clinic. The technician notices irregular baseline fluctuations and frequent interference in multiple leads. The patient denies any movement or discomfort. What is the most likely cause of the artifact? A. Muscle tremors due to anxiety or Parkinson's disease. B. Poor lead connection due to dry skin or lotion. C. Electrical interference from nearby equipment. D. Loose electrodes due to excessive sweating. Answer: C. Electrical interference from nearby equipment. Explanation: electrical interference, often called 60-cycle interference or AC interference, appears as regular, consistent artifact across multiple leads. It is caused by nearby electrical devices like computers, mobile phones, or fluorescent lights. Optical muscle tremors is incorrect because muscle artifacts appear as irregular baseline movements, not uniform interference. Option B, poor lead connection, is incorrect because it would cause intermittent loss of signal or baseline wander, not continuous interference. Option D, sweating, is incorrect because excessive sweating increases skin impedance but does not cause uniform interference. Key concept: electrical artifacts are identified by their consistent, repeating patterns. Always check for nearby sources of interference before repeating the EKG. Question 10. Topic: cardiac rhythms, atrial fibrillation versus atrial flutter. 78-year-old male presents to the emergency department with palpitations and dizziness. His EKG shows heart rate of 140 BPM, an irregular rhythm, and no distinct P waves. What is the most likely diagnosis? A. Sinus tachycardia. B. Atrial fibrillation of fib. C. Atrial flutter with variable block. D. Multifocal atrial tachycardia. Answer: B. Atrial fibrillation of fib. Explanation: atrial fibrillation is characterized by irregular rhythm, no distinct P waves, instead fibrillatory waves, variable ventricular response. Optional sinus tachycardia is incorrect because sinus tachycardia has a regular rhythm with P waves before ERS. Option C, atrial flutter, is incorrect because atrial flutter has sawtooth flutter waves and often a regular ventricular response. Option D, MAT, is incorrect because MAT has at least 3 different P-wave morphologies with an irregular rhythm. Question 11. Scenario-based. Topic: pacemaker malfunctions and EKG findings. A 70-year-old patient with a history of heart failure and a dual-chamber pacemaker presents to the cardiology clinic for follow-up. His EKG shows pacing spikes without a corresponding ORS simplex. What is the most likely cause? A. Pacemaker oversensing. B. Pacemaker failure to capture. C. Lead displacement. D. Battery depletion. Answer: B. Pacemaker failure to capture. Explanation: failure to capture occurs when the pacemaker fires, spike is present but an ORS complex follows. Common causes include lead displacement, electrolyte imbalances, or insufficient pacing voltage. Optional oversensing is incorrect because oversensing causes the pacemaker to inhibit pacing when it should be firing. Option C, lead displacement, is possible but would usually result in intermittent loss of pacing, not consistent failure. Option D, battery depletion, is incorrect because low battery power leads to slower pacing or failure to pace entirely, not failure to capture. Question 12. Topic: since segment changes and myocardial ischemia. A 60-year-old male presents to the emergency room with chest pain that improves with rest. His EKG shows since segment depression in leads VVV. What is the most likely diagnosis? A. Anterior STEMI. B. Non-elevation myocardial infarction and STEMI. C. Pericarditis. D. Prinzmetal's angina. Answer: B. Non-elevation myocardial infarction and STEMI. Explanation: since segment depression in leads VV suggests myocardial ischemia, often due to a partial occlusion of a coronary artery, and STEMI. Optional STEMI is incorrect because STEMI shows elevation, not depression. Option C, pericarditis, is incorrect because pericarditis causes diffuse elevation. Option D, Prinzmetal's angina, is incorrect because Prinzmetal's angina causes transient elevation due to coronary vasospasm. Question 13. Topic: first degree AV block versus sinus bradycardia. A 65-year-old man with a history of hypertension comes in for a routine EKG. His heart rate is 58 bpm and the EKG shows a prolonged interval of 220 ms with a regular rhythm. What is the most likely diagnosis? A. Sinus bradycardia. B. First degree AV block. C. Second degree AV block type 1. Wenkebot. D. Second degree AV block type 2. Mobit-Romed. Answer: B. First degree AV block. Explanation: first degree AV block is characterized by interval 200 ms 0.20 sec consistent interval no drop. QRS complexes. Optional sinus bradycardia is incorrect because sinus bradycardia is simply slow heart rate 60 bpm without prolonged interval. Option C, Wenkebot, is incorrect because type 1 AV block has progressive lengthening until a beat is dropped. Option D, Mobit-Romed, is incorrect because it features sudden dropped beats without interval changes. Question 14. Scenario-based. Topic: ventricular tachycardia and emergency response. A 55-year-old man presents to the ER with palpitations and dizziness. His EKG shows a wide complex tachycardia at 180 bpm with no visible P waves and a monomorphic pattern. Blood pressure is 80/50 Hg. What is the next best step? A. Administer romanodinosine. B. Perform immediate synchronized cardioversion. C. Give Roman eta blockers and monitor. D. Obtain a second EKG before proceeding. Answer: B. Perform immediate synchronized cardioversion. Explanation: the patient has unstable ventricular tachycardia VT with hypotension, which requires immediate cardioversion. Option Q adenosine is incorrect because adenosine is used for supraventricular tachycardia SVT, not VT. Option C, beta blockers, is incorrect because VT needs immediate electrical intervention if unstable. Option D, second EKG, is incorrect because delaying treatment in unstable VT is dangerous. Question 15. Topic: Torsades, points, and UT prolongation. A 40-year-old female with a history of hypokalemia and UT prolongation suddenly collapses. Her EKG shows a polymorphic ventricular tachycardia with a twisting ORS complex. What is the most appropriate treatment? A. Immediate defibrillation of romanmagnesium sulfate, a romanamodorone, romanata blockers. Answer: romanmagnesium sulfate. Explanation: Torsades points is a type of polymorphic VT seen in QT prolongation. First-line treatment with romanmagnesium, which stabilizes the cardiac membrane. Option was defibrillation, is only needed if the patient is pulseless. Option C, amiodarone, can further prolong the QT interval and worsen the arrhythmia. Option D, beta blockers do not treat torsades directly. Question 16. Topic: STEMI identification by coronary territory. A 58-year-old man presents with crushing chest pain radiating to his left arm. His egg shows elevations neuromen tomnev. Which artery is most likely occluded? A. Left anterior descending LAD artery. B. Right coronary artery OCA. C. Left circumflex artery LAX. D. Posterior descending artery PDA. Answer: B. Right coronary artery OCA. Explanation: inferior STEMI elevation Roman-Tumruv was caused by RCA occlusion. Option called LAD is incorrect because LAD occlusion causes anterior STEMI VV elevations. Option C, LCX, is incorrect because LCX occlusion causes lateral STEMI elevations in IAVA VV6. Question 17, scenario-based. Topic: pacemaker malfunctions. Oversensing versus undersensing. 72-year-old man with pacemaker presence with dizziness. His IC shows absence of pacemaker spikes and slow native rhythm. What is the most likely pacemaker malfunction? A. Failure to pace. B. Failure to capture. C. Oversensing. D. Undersensing. Answer: C. Oversensing. Explanation: oversensing occurs when the pacemaker falsely detects extraneous signals, e.g. muscle activity, and inhibits pacing. Optional failure to pace is incorrect because pacing spikes would be absent but with no underlying rhythm present. Option B, failure to capture, is incorrect because pacing spikes would still be visible without corresponding ORS complexes. Option D, undersensing, is incorrect because undersensing leads to inappropriate pacing, not lack of pacing. Question 18. Topic: hyperkalemia and egg changes. A patient with chronic kidney disease presents with weakness and palpitations. His egg shows tall peak T waves, loss of P waves, and widening of the QRS complex. What is the most urgent treatment? Romidaron, aroma calcium gluconate, aromaneta blockers, aromadigoxin. Answer: calcium gluconate. Explanation: hyperkalemia can cause life-threatening conduction abnormalities. Calcium gluconate stabilizes the cardiac membrane and prevents arrhythmias. Optional amiodarone is incorrect because it does not reverse hyperkalemia. Option C, beta blockers, is incorrect because they do not treat hyperkalemia. Question 19. Topic: third degree AV block and pacemaker indications. A 78-year-old man presents with fatigue, dizziness, and syncope. His EKG shows complete dissociation between P waves and RS complexes, with atrial and ventricular rates that do not correlate. The ventricular rate is 35 bpm and the QRS complexes are wide. What is the most appropriate next step? A. Administer omanopropine. B. Prepare for transcutaneous pacing. C. Administer oman eta blockers. D. Reassure the patient and monitor. Answer: B. Prepare for transcutaneous pacing. Explanation: the patient has third degree complete AV block where the atria and ventricles beat independently. Wide QRS escape rhythms indicate a low ventricular pacemaker site below the AV node, leading to a dangerously slow rate. Optional atropine is incorrect because atropine is ineffective in high degree blocks. Option C, beta blockers, is incorrect because they would worsen the conduction block. Option D, reassure and monitor, is incorrect because this is an emergency requiring pacing. Question 20, scenario-based. Topic: atrial fibrillation with rapid ventricular response. A 67-year-old woman with a history of hypertension and diabetes presents with shortness of breath and palpitations. Her heart rate is 140 bpm and her EKG shows an irregular rhythm without distinct P waves. Blood pressure is 130/25 mmHg. What is the best initial treatment? Amiodarone, romanidiltism, or omaneta blockers. C. Immediate synchronized cardioversion of romandigoxin. Answer: romanidiltase or omaneta blockers. Explanation: the patient has atrial fibrillation AF with rapid ventricular response RVR. Rate control, diltiazem or beta blockers is the first-line treatment if the patient is stable. Optional amiodarone is incorrect because it is used in rhythm control, which is not first-line in stable AF. Option C, cardioversion, is incorrect because cardioversion is used only for unstable patients on new onset 48 hours. Option D, digoxin, is incorrect because it is slower acting and not the first-line choice. Question 21. Topic: hyperkalemia and EKG changes. Emergency management. 55-year-old man with end-stage renal disease presents with weakness and palpitations. His EKG shows tall peak T waves, loss of P waves, and widened RS complex. What is the most urgent treatment? Omexim gluconate, romanoidium bicarbonate, romanoinsulin with dextrose, romano of diuretics. Answer: Roman calcium gluconate. Explanation: hyperkalemia can cause fatal arrhythmias. The first-line treatment Roman calcium gluconate to stabilize the cardiac membrane. Option B, sodium bicarbonate, and option C, insulin dextrose, help lower potassium but do not act immediately to protect the heart. Option D, loop diuretics, is ineffective in end-stage renal disease. Question 22. Scenario-based. Topic: Torsades points and UT prolongation. A 45-year-old woman with a history of hypokalemia and recent antibiotic use suddenly collapses. Her EKG shows a polymorphic ventricular tachycardia with a twisting QRS pattern. Torsades points. What is the most appropriate next step? A. Immediate defibrillation of Roman magnesium sulfate, Roman amiodarone, of Roman lidocaine. Answer: of Roman magnesium sulfate. Explanation: Torsades points is a form of polymorphic VT associated with QT prolongation. The first-line treatment for Roman magnesium sulfate, option defibrillation, is only needed if the patient is pulseless. Option C, amiodarone, can actually prolong the QT interval and worsen torsades. Option D, lidocaine, is not effective for torsades. Question 23. Topic: STEMI versus pericarditis. Differentiation. 50-year-old man presents with chest pain that improves when sitting forward. His EKG shows elevations in all leads with segment depression. What is the most likely diagnosis? A. STEMI, elevation, myocardial infarction. B. Pericarditis. C. Aortic dissection. D. Pulmonary embolism. Answer: B. Pericarditis. Explanation: pericarditis shows diffuse elevations across multiple leads and depression, which is not seen in STEMI. Option STEMI is incorrect because STEMI has localized elevations in specific coronary territories. Option C, aortic dissection, and option D, pulmonary embolism, typically do not cause diffuse elevations. Question 24. Scenario-based. Topic: ventricular tachycardia versus SVT with aberrancy. A 70-year-old man presents to the ER with palpitations and dizziness. His EKG shows a wide complex tachycardia at 180 BPM with no P waves and a monomorphic QRS pattern. Blood pressure is 95/60 mmHg. What is the best next step? A. Administer Roman idanosine. B. Perform synchronized cardioversion. C. Give Roman beta blockers. D. Obtain a second EKG before proceeding. Answer: B. Perform synchronized cardioversion. Explanation: why complex tachycardia at 180 BPM with hemodynamic instability is most likely ventricular tachycardia (VT), which requires synchronized cardioversion. Optional adenosine is incorrect because it is for SVT, not VT. Option C, beta blockers, is incorrect because they are not first line for unstable VT. Option D, waiting for a second EKG, is incorrect because delaying treatment in unstable VT is dangerous. Question 25. Topic: pacemaker malfunctions. Failure to capture versus oversensing. 75-year-old man with dual chamber pacemaker presents with fatigue and bradycardia. His EKG shows pacemaker spikes without corresponding ORS complexes. What is the most likely pacemaker malfunction? A. Failure to pace. B. Failure to capture. C. Oversensing. D. Undersensing. Answer: B. Failure to capture. Explanation: failure to capture occurs when pacemaker spikes are present but do not result in ORS complexes. Option was failure to pace is incorrect because there are visible pacing spikes. Option C, oversensing, is incorrect because oversensing causes a lack of pacing spikes, not fade ORS capture. Option D, undersensing, is incorrect because undersensing would lead to irregular pacing, not fade ORS complexes. Question 26. Topic: STEMI versus STEMI and EKG interpretation. A 58-year-old man presents with crushing chest pain radiating to his left arm. His EKG shows depressions in leads with a V and T wave inversions. Troponin levels are elevated. What is the most likely diagnosis? A. elevation myocardial infarction, STEMI. B. Non-elevation myocardial infarction in STEMI. C. Unstable angina. D. Pericarditis. Answer: B. Non-elevation myocardial infarction in STEMI. Explanation: STEMI presents with depressions, T-wave inversions, and positive cardiac enzymes. STEMI option A would show elevations instead. Unstable angina, option C, has similar EKG findings but normal troponin levels. Pericarditis, option D, would show diffuse elevations, not localized depressions. Question 27. Scenario-based. Topic: supraventricular tachycardia. SVT management. 32-year-old woman presents with sudden onset palpitations and dizziness. Her EKG shows regular narrow complex tachycardia, 180 bpm with no visible P waves. Vagal maneuvers fail to terminate the rhythm. What is the next best step? Homonymia of Romano nanosine, of Romanopine, of Romanopinephrine. Answer: Roman adenosine. Explanation: SVT is a narrow complex tachycardia that originates above the ventricles and is treated with vagal maneuvers first, followed by Roman adenosine. Amiodarone, option A, is used for ventricular arrhythmias, not SVT. Atropine, option C, is used for bradycardia, not tachycardia. Epinephrine, option D, would worsen SE. Question 20. Topic: bundle branch blocks. Right verses. Let BBB. 67-year-old man undergoes an EKG for intermittent dizziness. Is EKG show RS duration 120 ms with an RR pattern. Rabbit ears in lead V and wide S wave in lead I. What is the most likely diagnosis? Say left bundle branch blow BB. B right bundle branch block or BB. C ventricular tachycardia. D atrial flutter. Answer: B right bundle branch block or BB. Explanation: OBB is identified by a widened QRS 120 ms with an RR rabbit ears pattern in a V and wide S wave in lead I. BBB. Option A would have broad S with deep S wave in a V and no RR pattern. Ventricular tachycardia. Option C would present with fast monomorphic wide complex tachycardia. Atrial flutter. Option D is an atrial arrhythmia and does not cause bundle branch blocks. Question 29. Scenario-based. Topic: atrial flutter versus atrial fibrillation management. A 72-year-old man with hypertension and EHF presents with palpitations and shortness of breath. His EKG shows a regular narrow complex tachycardia with a sawtooth pattern of P waves in La Roman Romna and F. His blood pressure is 125/8 mmHg. What is the best next step? Omnodultasm or beta blockers? B. Immediate synchronized cardioversion of Romnidigoxine, Romanamiavirone. Answer: Romanultasm or beta blockers. Explanation: atrial flutter is managed similarly to atrial fibrillation, with rate control as the first step in stable patients. Diltiazem or beta blockers. Synchronized cardioversion, option B, is used if the patient is unstable. Digoxin, option C, is less effective for acute rate control. Amiodarone, option D, is used for rhythm control in refractory cases. Question 30. Topic: pacemaker malfunctions. Failure to sense versus oversensing. 68-year-old man with pacemaker for sick sinus syndrome reports episodes of dizziness. His EKG shows no pacing spikes during bradycardic episodes. What is the most likely pacemaker malfunction? A. Failure to capture. B. Failure to pace. C. Failure to sense under sensing. D. Oversensing. Answer: C. Failure to sense under sensing. Explanation: failure to sense occurs when the pacemaker fails to detect intrinsic cardiac activity, leading to pauses. Failure to capture, option A, would show pacing spikes without corresponding RS complexes. Failure to pace, option B, means no pacing spikes are generated at all. Oversensing, option D, happens when the pacemaker mistakenly detects external signals as heartbeats, inhibiting pacing.